one word, I would like to welcome all of you to this fantastic session. And we are trying to do it this time a little different. And it's a more of a closed session than an open invitation for everybody. So theme, as you all know, it's a discharge delay and their laws and awards. I'll directly go to the introduction of our moderator, Dr. Naveen Thomas. So Dr. Naveen Thomas, and I would like to first thank Dr. Lalu ma'am for giving a fantastic suggestion of Dr. Naveen Thomas. It was very easy for me to coordinate with him and arrange this program so quickly. So he was very approachable and straightforward. So thank you for that, Dr. Naveen first. About his professional qualification, he has finished his MS and DNB in general surgery, MCH in pediatric surgery, and MPhil in health systems management from BITS. So we are very happy to have a person who had a blended knowledge both as a clinician and an administrator. So he has joined Bangalore Baptist Hospital in 1988, soon after his internship, and continues to be associated with the hospital till date. He was the director for Baptist Hospital for a 7-year term from 2014 to 2021. Currently, he is a general surgeon and pediatric surgeon, continuing to serve as a senior advisor and head of networking and development of Baptist Hospital. He worked as a fellow in pediatric transplantation at Children's Hospital, Sydney in the year 2009-11. And he was also an associate clinical lecturer at Sydney Medical School during this period. He is also a NABH principal assessor. He is married to Dr. Asha Thomas. She is a radiologist and working with the Baptist Hospital again. And is also blessed with 2 children, Amit and Nikita. So thanks for taking our invitation to be a moderator of this session, sir. And I would like to officially hand over the session to you. Thank you.
Yeah, thank you very much, Renjith, Father Johnson, the CAHO folks who are with us or who will be joining. I think it's a very special privilege to connect with all the eminent people who have agreed to share from their experience. I think that is very special. So what we hope to do today is to bring from the practical aspects and not to dwell on the theoretical ones. So it is an excellent blend that we have got, and must congratulate, starting with Father Johnson. Yes, I think you gave the push. I think, Renjith, you contacted each person, and CAHO office helping, and thank you for that. Now, just wanted to start the whole thing in process. Just wanted to say our own experience here when it comes to the discharge process, it is so important to the patient that it is on our interest to make sure they have a good experience as they go. Otherwise, all they remember is all the good work which has been done in the past. Before that, prior to that, everything is forgotten if we don't really concentrate on this. Therefore, I think this session is going to be very, very important, applicable, interesting, and we will try to keep it very crisp. Just sharing a couple of things from our own experience. One is, in order to improve, look out for the low-hanging fruit. I'll just give you an example. We were really scratching our heads, saying suddenly it was noted that, one of the many things which were jotted down as part of the process was printing, once the bill was ready, that the person had to go and collect it, bring it back to the ward, and then the ward nurse had to take it and give it to the patient concerned. So somebody said, why don't we just, as soon as it is made, why don't we just set up the things so that it is printed automatically in the wards? And everyone said, wow, we never thought of that. How is it that we missed such an obvious thing. So that was a low-hanging fruit. It may or may not be there, low-hanging fruits, but look out for them. It may be just in front of you. So 1.5 hours chopped off, on an average. So, brought in immediate results. That was also because we were not so smart till then. That may be the reason. And if you've been smart all the while, you may not see too many of those low-hanging fruits, but watch out for that. The other thing that really worked was reward preparation for discharge, in the sense we publicly say that this particular department had so much percentage of it was planned discharge, and acknowledgement itself worked as a reward, and be consistent in acknowledging and present the truth. So it works like a carrot and stick, but make the carrot stick. Really stick out in one sense. The other thing that we talked to clinicians was correct the expectations. What happens in many places is that the consultant comes, we know that the consultant formally approves discharge. Your time starts now and finishes off when the patient leaves the clinical unit, and it's written, we have put it down in NABH also as the discharge period, the time taken. Now, correct the expectations. Now, when the consultant goes in the morning and talks to the patient, what does he say? He or she says, I will discharge you and you may take these medicines and whatever, and she or he walks off. In the patient's mind, he has already been discharged. Instead, if the consultant says, I will discharge you this evening, and by afternoon, all processes are ready, by midday it is presented, wow, you have beaten the expectations. And the patient says, such an efficient hospital or a healthcare organization. It's not about buttering them up. It is not, it's about correcting the expectations. So set that right in the beginning, and you have a totally different expectation. We found that this was also a low-hanging fruit. So may be applicable, and suddenly you find that, wow, the expectation, you suddenly look through the patient's eyes from a different perspective that we always neglected. So just mentioning few practical things which happened, and we instituted, and we're grateful looking back, but lots to do still. And we are here to learn from each other. And we will straight away go ahead. And the opening batsman for today is Mr. Devanand Kolothodi. Yes, being the opening batsman is a tough thing, and serves as the regional CEO for Telangana and Andrapradesh cluster of Aster, responsible for administration and P&L of 6 hospitals and Aster labs under the cluster. I won't go through the whole thing. So much is there in the CV, and very impressive. We are so happy to have you with us. And I liked one.
Thank you so much. So once again, at the outset, I would thank CAHO, Mr. Renjith, Father Johnson, and the entire organizers, Prakash. The follow-up have been fantastic. This is the first time I'm, representing or presenting something in the CAHO forum. I'm a member, but it's the first occasion. But the follow-up that CAHO has done is fantastic. I must definitely admit that. So I know that there is a time constraint. A lot of esteemed speakers are there, panelists are there, and I'm also equally eager to learn from them and hear from them. This is the good practices that we should learn and exchange with each other to give the best care and comfort to our patients who seek that kind of solace from our hospitals. So discharge, as Dr. Naveen said, it's one of the most important thing that we all have been looking at. Correcting the discharge stat always becomes an indicator for our performance. So a few things, I don't want to go into the theory at all. I just want to focus only on the practicalities. That's what Dr. Naveen said. So on the subject itself, their loss is ours. There is no question at all. It is our loss. Throughout it is going to be our loss. The way we take it seriously or not, it's going to impact you in a longer run. So it is very important that we focus on this discharge delays or, to make it more smoother. So a few things that we have done was, first and foremost, is that in every hospital may be different. They have a different process because, the process that is followed for a discharge in my hospital may be slightly different with other hospitals. So first of all, what we have done in the cluster that I operate is that to understand the process well. So we have gone through the step by step, the process of all the discharges at different hospitals. And we found that there are differences. We try to make it more uniform. Even then, there are differences in various hospitals because of various, geographical issues and the kind of, doctor mix that you have. The hospital has more of, I would say the retainer doctors. Sorry to use that word, but they may come on time. But as a visiting doctor admitting a case may not be, the case in some hospitals. So I see this in my Hyderabad hospital, where most of my doctors are on a fee-for-service model. So where discharge is slightly difficult to manage. But then the process, once we know well, the next thing is to make someone accountable for that. So accountability is very, very important. So there should be someone driving the whole discharge summary. So we have identified somebody who has the particular job of, focusing on the discharge. The moment that the previous day, there's a planned discharge and there is an emergency discharge. So there are two things. I'm only talking about the planned discharge at this point of time. So for the planned discharge the previous day, this person is in touch with the ward or the doctor to understand whether this patient is likely to get discharged, and he'll trigger the discharge process from the previous day. And one of the major thing when we looked at the process, what we found was that there were three major issues. One was on the billing. Second was on the discharge summary. Third was on the audit, especially the pharmacy audit or pharmacy return medication or discharge medications. So what we have done on the bill, I'll be brief because I think a lot of other people also would be focusing on these subjects. So what we have done is only I'm going to focus. One, we introduced a bill by D system. This was actually introduced in one of the Aster hospital. Actually speaking, it was introduced in Aster Medcity at Kochi, and which we have thought is a good concept to be followed at all our hospitals. So bill buddy is a concept where somebody from the billing with a laptop or a computer, with a printer, with a paying, UPI or a credit card machine goes to the patient's room every day and explains the bill to the patient. This is especially very useful for the cash patients where they have a lot of confusions. So every day the bill is explained to the patient, means the last day will be only one day bill pending, which will not have much confusion. Otherwise, the patient will have a lot of confusions, queries to handle. All those are settled on a daily basis and there is a signature taken. Payment is also collected on that day so that the final day payment will be less. Final day, the confusions or the concerns of the bill by the patient will be less. So BillBud is a fantastic system that we found to do that. Also gives a pressure on the people to do billing properly. On the billing properly, when I say the nursing forgetting some services to be updated, or the pharmacy not entering the data. So all those things get corrected on a daily basis, we understand. And second thing is to audit the bill or the discharge or the patient file on a daily basis by a nurse as well as by the pharmacist. This also gives a lot of things that get confused otherwise at the end, because the audit done on a daily basis will clear most of the doubts. All services will be billed on a daily basis, which is explained to the patient also. So it pushes to a greater extent. Once the audit is done, there is no problem in terms of the returns and other things. So once the audit is done, the previous day itself, the pharmacy guy who is going, or the material guy is going and checking this audit, will initiate that, since the patient is probably leaving by tomorrow afternoon, he needs only that kind of medications to be left at the bedside. So those returns are initiated the previous day itself. So next day, in case it stays back, again, there will be an ordering made, but otherwise it is only kept till the noon. Just all the things are returned on the previous day. Initiation will happen. Morning itself, the returns will happen. And third thing, the most important thing is the discharge summary. We all know, doctor will say, like Dr. Naveen said, they come for rounds, they say you are discharged and the time starts then. So what happens is that the doctor, if he's a surgeon, it is all the more difficult actually. You know, they say that you are discharged and they'll go to a theater. The DMOs will prepare the discharge summary while the consultant is in the theater performing a surgery. He'll come at 11 o'clock or 12 o'clock out, and then only he looks at the discharge summary. So here we have also brought in some digitalization basically. We are bringing an app called Dr. Mate, where the doctors can see the discharge summary in their mobiles. They also have an option to do a voice, recorded option to the DMOs, where they can direct the DMO to correct the discharge summary, or they can correct in the mobile itself. Because, they can't be in front of a system at most of the time. So they can correct those things in the mobile itself. So that's something which we have initiated. So these three things have brought the discharge timing to a very greater extent. And the most important thing I would consider is that, the leadership has to be completely accountable for this. So it is also a KPI for all our leaders, at a greater level, at a higher level. The unit head is one of the KPI is to reduce the discharge stat. So he gets a brownie points, during the performance appraisal, and also it is very evident that it's a very serious business. So you have to make your patient happy at the time of discharge. I'll stop it here because I would also be eager to hear from others. So that's it from my side.
Resource person is a surgeon, branched off into emergency medicine, fellowship in UK, trained in trauma and disaster management in Israel. So Dr. Atanu Barthakur, so much more to talk about him, but we will leave the whole stage to him. Special interest in developing emergency medicine and development of organized trauma care in the Northeast, isn't it? And it's excellent that you are with us. Over to you without wasting much time. Thank you
for giving us this opportunity to speak on a subject which is very, very important, and particularly in the Northeast part of the regions. Only 3 hospitals in the entire Northeast we have got NABS accredited hospitals. So there is no system at all. In my hospital, I'm working in a Healthcity hospital. This is a premier hospital. Basically, we are focusing emergency trauma, critical care, cancer, heart surgeries. But most, I'm sorry to say that there is always a delay. And the people, and there is you have in your team, you have said that loss, because from my point of view, loss is from the hospital side. So there is a lot of waiting patients. And so what we did, and there is an emergency ward. Suppose rooms are not ready, we are keeping this group of patient in that emergency ward. So early management skill, we can start in that emergency ward. Then later on, we'll shift from the emergency ward to the other part, even in the ICU also. The most important, delays discharge is one of the most common problem in our hospital that needs to be addressed in order to increase the occupancy of the bed and to reduce the long waiting time. Long waiting time for the patient causes frustration, which reflects on the patient dissatisfaction. In order to reduce the delay in discharge, hospital needs to proper coordination and the coordination about the different staff. If you go through the Fishbone analysis, the most important, we did recently before NABS procedures. So the most important role plays the consultant. So late rounds, no pre-planned discharge, and discharge summary is always inadequate. Then the billing part, then the pharmacist and other things. So there is no coordination between the consultant, there is no coordination between the consultant, nurses, and the other staffs. So what we need a corrective procedures for all the things. The most important is what we did the full-time, we are taking now full-time consultant, and they are all accountability. So discharge summary should be prepared early part of the morning, so that we can discuss. Our time tag is the 4 hours from the when the consultant plan for the discharge, then ultimately discharge should be done at the 4 hours. So if they will not do, immediately our floor managers, they will go for the consultants. And our previous speaker said that our surgeons, they are so busy, because then we did the morning round should be at least 8 o'clock. If they have got a surgery, before surgery, they can finish all the things. And the deputy medical consultant, deputy consultant, and resident medical officers. They must be well trained. And most of the time, if patient is shifted from the ICU to the emergency, suppose in the ward, there is no heading about the course in the hospital, course in the ICU particularly, and that again you have to check the ICU flow charts about the patient in the ICU, what medicines he got, if transfusion medicine, patient received transfusion, blood transfusion, if that is not written in that course in the hospital part, then ultimately again, there are a lot of issues actually. So for that, we need a concrete teamwork actually, basically from a doctor's point of view, nurses, then the billing, then the ultimately the flow managers. So recently, after that, doing all these things, so now our discharge time is, initially our target is the 4 hours. Now it's come out around 5-6 hours. But a lot of things we'll have to go for it. So our target should be within 4 hours. And particularly for the TPA patients, that is always a very, very difficult issue. And we are having all the corporates like All India, ONGC. For that group of patients, also there is a lot of problem. For TPA particularly, if you plan for the discharge evening, then the TPA persons are everywhere, is not available. That patient, again, we'll have to keep that group of patient in the ward or cables. So that is a major issues. So what I feel, we should come up with concrete guidelines, evidence-based guidelines, so that we can go for it. Thank you very much. Thank you.
Thank you. Thank you. That was excellent. And Chris, you have spearheaded this in the Northeast, and you have led this effort. So thank you for sharing from your experience, and also the as Director Medical Services of Healthcity Hospital, Guwahati.
Sir, can I ask?
Yes.
So we need actually support from the CAHO, because in this part of the region, even in the government hospitals, they don't have any proper guidelines. So if you'll come out with a proper guidelines, how to admit the patient, what are the emergency patients, how do you deal, and particularly the medical legal issues, there are a lot of confusion. So I need your support, and I will definitely give our platform, and the rest of the hospitality part will take care. So definitely we need your support to develop all the guidelines and other things. Thank you.
Yes, thank you for that. I think some of the things vary from state to state, but there are a lot of common things as well. So we can share that. Some are already there in as NIBH guidelines, and CAHO will pitch in, I'm sure. That will be a thank you for that suggestion. We will move on. We will, the Dr. Ilankumaran Kaliamoorthy. So, after the surgeon, we come to the anesthetist. They are the ones who work on the right side of the blood-brain barrier. Dr. Ilankumaran is currently working as a liver anesthetist intensivist, CEO of Rela Institute, 450-bed multi-specialty JCI accredited hospital. It's one of the largest liver transplant centers in the world. So for both adults and children, so it's fantastic. Published more than 60 articles, papers in peer-reviewed journals, books. So we can't wait to listen to you. Over to Dr. Ilankumaran.
Thank you very much. Good afternoon, all of you. Very nice to meet all of you at this junction. I'm sure all of you would agree that it's one of the most important critical point we are facing in many hospitals. Admission delay and discharge delay. Both of them, patients are directly getting involved. And our core business is patient care. And whenever there is an issue in the patient care or core business, of course, the business will get affected. So what we have done is, a few years ago, we knew that we are facing a major challenge in discharge process. So we have taken data-driven approach. Through HA system, we wanted to analyze where we are stuck, what's the reason behind that, how can we improve it. So I thought I will show some of our data, which we have gathered a few years ago, to show you how we have understood our problem and we have resolved the problem. So this is the data from few years ago. If you look at the data, the blue one, only 17% of the patients were discharged from our hospital. I'm talking about at the beginning of our hospital. After 3 p.m., nearly more than 80% of our patients got discharged after 3 p.m., which is not a good sign. Between 3 to 6 p.m., 26%. Between 6 to 9 p.m., it's a 43%. After 9 p.m., 14% of the patients got home. That's not a good thing to happen. We understood that. We further analyzed the data, and then, 1 second. Yeah. And initially I thought it may be due to insurance issues. And after further analysis, I came to know that it's not only the insurance, even self-paying patients are facing the same issue. Most of the patients left the hospital after 3 p.m. So these kind of data analysis will help us to get clarity of where exactly we are stuck. And then I tried to understand why there is a reason for the delay. 8% of the time took for pharmacy clearance, and pharmacy to billing took 14% of the time. Billing to audit only took 2% of the time. Audit to finance clearance took 30% of the total discharge time. Unfortunately, the last bit, finance to physical discharge, 46% of the time. That shouldn't be the ideal case. Normally, I would have assumed that because of the billing clearance, patients are going home very late. But I came to know that in our center, even after clearing the billing, it took almost a few hours for the patient to leave the hospital. Then I realized that it's because of only one issue. That's a discharge summary issue. So I tried to understand what's the issue behind the discharge summary. This is the data I have gathered through a lot of analysis. And I came to know that only 24% of our patients were planned to get discharged the previous day. More than 50% of our patients were unplanned discharge, which means that when a doctor goes for rounds the previous day, they don't take a decision on whether the patient can go home on the next day or not. And we realized that this is the area we need to target. We need to focus on the consultants. We need to bring consultants on board to understand the problems their patients are facing, because consultants are providing fantastic clinical service. Sometimes it might not be their focus about sending the patients home very quickly. And unless otherwise the management team goes and talks to the consultant, it's very difficult for them to understand the reality. So I brought them, I brought the clinical leads and the key consultants to the boardroom, and I put these slides in front of them. And then I showed we need to make a huge change in terms of planned discharge, getting the discharge summary ready, and we need to ensure the patients go home early. And if you look at this slide, more than 50% of the summary were approved after 12 p.m. Again, I have focused on this data because to convince a doctor, we need to be evidence-based. If you go and tell them that please have a planned discharge or please approve your discharge summaries very quickly, they won't believe that. Unless otherwise we show data to them, it's very difficult to convince them or make changes in their practice. So I showed them that they have to make a huge change in terms of clearing the discharge summary. So we have made a lot of interventions to improve the process. The first one is we have informed the consultants to ratify the list of planned discharge the previous day itself. And all the planned discharges were initiated by the nursing team in the HIS system by 6-7 o'clock, so that the process will get initiated. And the discharge patient rounds to be completed by the consultants before 10 o'clock. Medicines will be returned to the pharmacy the night itself. Only we are keeping only the morning set of medicines for the patients. And the summaries will be ready overnight by the DMOs. And during the consultant rounds, the consultants will clear the summaries. And we have also allocated dedicated PAs and transcriptionists for final approval and hand out to the patients. And it's really important to set up a dedicated team of discharge nurse and IP manager for coordinating the entire process. After making these practices, now we are able to send most of the patients before 3 p.m. And our discharge time, average time, has also come down to 4 to 5 hours. I think what I wanted to convey is whenever there is a problem, I think it's better to understand the data properly, deep dive the data, find out what's a bottleneck. Maybe 10 reasons may be there. I think we have to catch the most important bit for that particular hospital and then try to solve it. Thank you very much.
Thank you for that. Thank you for that. That was excellent. I think what comes out is that analyzing an issue and coming out with data which is valid. You know, as somebody said, 83.3% of all statistics are made up on the spot. But here it is valid, real data, which, you know, nobody can, no stakeholder in the hospital will be able to refute. You have presented that effectively, and I think it's an example to all of us, knowing that that is something that we must do, and stemming from that, moving on to the interventions. And it's good to see that that was instituted in a very high volume and difficult workplace, liver transplant center. So thank you so much.
Thank you.
And Dr. Mithun Rathen from Thiruvananthapuram, and both MBBS MD from Kochi Amrita Institute, and has been associated with PRS Hospital for a long time, and joint managing director, NABH accreditation coordinator and consultant in general medicine. And he was also the Kerala Private Hospitals Association secretary. And it's fantastic to have you with us. Over to you, without wasting much time. Over to you, Dr. Rath.
A very good evening to all of you. Firstly, I would like to thank Mr. Renjith for inviting me to be part of this very elite group of panelists, especially with Dr. Naveen sir as a moderator. Sir was our assessor, NABH assessor 5 years back. I think sir will remember. Yeah. And also Father Johnson, thank you so much. Coming to the topic, actually, we are still a work in progress. I think, like Rela said, we are in that phase where we have realized that there are a lot of issues in discharge summary. We are in that first phase where we need to do a lot of interventions. We are trying day by day, but still, as another speaker pointed out, it is a very challenging task. So we are having every day we have a morning meeting and we discuss. So main issue which we found out was, there are two kinds of patients. One is the cash paying patient. They are usually okay. If they have the money, they will pay and they will go fast. That is okay. Then there is the insurance patients, so the TPAs. So the TPAs was a big bottleneck for us. It used to take 7 to 8 hours if the queries are there for that patient. So we saw both of them. The solution required for both were different. So, so for the cash patients, yes, we have the DMO, we have the discharge medical officers. We have given clinical pharmacists to all the major consultants so that they'll enter the summary the previous day itself. At 11 o'clock, what we have told is by 11, all summaries have to be, or all discharges have to be approved by the doctors. Anything after 11 in PRS, now we are following the stick model. After 11 o'clock, they have to get the permission of the managing director or the medical director to pass the patient. They have to give a justification for that. Something like your antibiotic stewardship, they have to give a justification why you are discharging after 11 o'clock. It is working. So far, it is working. Then another thing is the discharge summary is not something where we can, just give it like that. Like another speaker pointed out, there are a lot of huge medico-legal implications. So we have also kept trained clinical pharmacists for doing the discharge summary stewardship. So many doctors in their haste, they will just enter something, whatever they feel like, especially surgery, they will just write under anesthesia, done, discharge. That's it. There is no course, nothing. So such things also now we are monitoring, and that also has given the surgeons confidence that there is one more layer of checking for the discharge summary so that it can be done a little more faster. And we insist on previous day discharges, but again, it is only around 20-25. Previous day preparation of discharge summaries, it is only 25% because many of our physicians included are lazy. So that is still a work in progress. I don't know how others are managing to get more numbers. Then another thing is we have made a dedicated WhatsApp group. So our HIS system is there, but still we have put another group where we have all the 5 the discharge summary stewards or the medical discharge summary officers who are updating on a real-time basis what time the doctor advised discharge, what time it reached the billing section, what time it reached the audit, what time the medicines were returned. Somebody pointed about returning the medicines the previous day. Practically, it's not possible in many cases because the last day also a lot of medicines are required, and eventually the return actually practically happens only in the afternoon at the time of discharge. Then another major issue we found out was many of our patients are coming from the southern state of Tamil Nadu. They come from 4 or 5 hours, so they usually have lunch and take the second dose of medicine, then only go. So we have formulated something called, I think it was there in Amrita when I was there. There is a discharge lounge. So if they want.
Thank you for that honest presentation. But you also shared what has worked for you and about the discharge lounge that you created, and it may be relevant in some places. Excellent. So thank you so much. Dr. Sister Beena, and from St. John's, that she passed MBBS, MS, and it was moving on to diploma in minimal access surgery, fellowship in lap surgery, then some healthcare design and implementation course in Melbourne, 1-year leadership course in US, then healthcare management and leadership through Rajagiri in Kerala, and as CEO of Holy Family Hospital. And so it's very special to have you with us. Over to you, and we will wait to listen.
Naveen, for your kind words of introduction. And at the outset, I would like to thank Father Johnson and Mr. Renjith and all the organizers from CAHO for giving me this opportunity. I think, as all of my previous speakers said, discharge delay is one of the most common complaints we get from almost every patient, or 50% of our patients. And especially in a city like Mumbai, where people are used with the culture of instant, everything they want on a click of a button, and there is a lot of dissatisfaction. When we analyzed, one of the main thing what we found was the TPA process. It gets a lot of time to clear or get the approval from TPA. So what the corrective measure, what we have taken now is correcting the expectation. So the discharge process for TPA, we started to begin at the time of admission. The admission counter informs at the time of admission to every patient who has TPA that your discharge process is going to get prolonged. It will take minimum 6 hours. So we correct their expectation. Secondly, in Mumbai city, we have a lot of visiting consultants. These freelancers makes our discharge process a little more unpredictable. So what we have requested them is kindly come before 12 o'clock, at least to visit your discharge patients, and make all pre-planned discharge plans on the previous day so that we can get ready with the discharge process the next day. The other delay was in the surgical specialties, because sometimes the discharge is done, but the residents and the surgeons go to the OT and they come back late. So most of the time nowadays we tell them to keep the discharge ready and don't take the printout, so that as soon as the discharge is declared, someone can take the printout and they go to the OT and get the necessary signatures from the doctors. Another area we found is there are also patients, a group of patients, once everything is ready, but they take time to clear the bill. For such patients, we also started taking advance from every patient. Also, we started to prepare interim bills so that finally they have to pay or settle a lesser amount of money, and they don't have to search for funds on the day of discharge. Sometimes also we come across such situations, the relatives are not there. The relatives are not there in the premises. So such patients, if everything is done, we move them to a different place so that the bed can be prepared for the next patient. We are also planning for TPA patient because the dissatisfaction grows as we are waiting for the approval and clearance, that we will display on the screen what is the status of their approval. And also for some of the patients, because they work in a different place, they have to come to the hospital. So such patients, we are planning to create on our website an online payment modality. So these are some of the interventions that we have taken.
Yeah, thank you so much. Thank you for that. A lot of points for us to take about display of the status of the approval itself, moving to a separate place if the patient is stable and waiting, and many other things that you have instituted practical. So thank you so much. And I'm sure we have taken note of some things which we can copy. Now we will move on to, it is Dr. Ananth Rao, CEO, Apollo Imperial Hospital, Chittagong, Bangladesh. Is that correct? The more than a decade of experience in healthcare sector as a scientist, biochemist, management, operations, quality, data analytics, business development, personal leadership role in mentoring and operations research. So I think you're the right person to share with us. Over to you. Thank you.
Thank you, Dr. Naveen, and thanks, Renjith, for tracking me down on this. It's been a pleasure to hear most of the previous speakers, and I would, assume to learn more from the forthcoming speakers. But I wanted to slightly give a different take to this entire topic because I'm thinking it in a slightly larger perspective to see. A lot of initiatives have been taken by most of the speakers who have spoken before me, and I usually at Apollo also. This is one of those important points that we chase administrators for and the operations team for. But I have slightly wanted to make certain points that reflects my thought process on this, and how we are trying to approach this issue. This is more from a third eye perspective. So the first and the most important thing is all corporate hospitals put together, right, in India would be about 67 to 70% occupancy on an average, right? So if that's the case, right, why are we running behind discharging a patient, right? Because there is 30% capacity, patient can stay, patient is comfortable, right? There is no shortfall of beds. The story shouldn't arise because the data is not showing you that we actually need those beds, right? So I was thinking when this topic came, of course, I'm talking of some 20 years ago, when I started my journey as operations. So I was just thinking, what is the hurry? Because everything is done by 4 o'clock, right? And after 4 o'clock, those beds are empty, or some of your beds are empty and only some of your beds get filled. So I was wondering, what is the story behind discharge process? So the first thing that we need to accept is that I think we are clearly looking at it from a hospitality perspective. We have stopped looking at it from a hospital perspective. So I think that's the first thing that I thought I should acknowledge myself, right? So that's why even 20 years later, since I started my journey, I'm sure this is more than a century old. The discharge process is always something that can be discussed through and through and through, and so this is the first thing that I thought I should bring to the perspective of everybody, because it's important to understand why we are chasing this. Right. So and I though I still don't have an answer, but I fairly know the answer that obviously everybody wants to get home before sunset. Let's put it that way. So that's the first point. The second point that I would like to share with all the fellow panelists and those on this call is to see what is the intervention that we need to do, because discharge is a very complex process, right? So we speak of pharmacy, we speak of medication returns, we speak of a clinical pharmacist. Role in vetting those, and then we speak of doctors being given data, driven approach or evidence-based approach. But I think, while a combination of all this works, do we know where the spanner needs to actually work, right? So, if you ask me this question, honestly, the answer is very, very difficult because it's unique, right? For a common system like NHS itself, every hospitals have different discharge processes. So, right, you would not assume, a country like us with so many hospitals and all of us having our own protocols, having common discharge. It's next to impossible. So I was thinking, where are those pain points? And we identified 3 pain points, right? So, which is already well articulated by the previous speakers. So mostly to do with discharge summary, because discharge summary is the most important document that the patient should get, right? And most importantly, it's also having its own legal requirements, etc. And the advice that the patient should get when the patient has to move out of the hospital. So that's point number 1. So I think that's where the problem starts in terms of finding apt time to do discharge summaries, right? It is almost impossible because you want your surgeon to be in the OT, you want your surgeon to be on the rounds, you want your surgeon to quickly follow up and attend an emergency laparotomy, and you also want him only to sign the discharge summary. It's a little unfair, right? So I think, setting expectations is also important, right? So Dr. Naveen, you mentioned that, and I think just now Sister Beena did mention that, right, about talking to people and telling them it's going to take 3 hours, 4 hours, right, or 5 hours. Right? This is an important thing. The third point that I would like to bring is all of us have problems with TPA. I think that's universally coming out, right? Is there something we can do about it? The answer is no, right? The only thing we can do is understand what queries have come in the last 1 year, which is what we did, right? We studied 1 year of queries that have come through particular TPAs, because in Bangalore it's easy to do that, and many other countries it's easy to do that because there are some kind of Medicare, etc. For example, in Singapore. So that's what we used to do. So I'm just sharing my experiences across the border as well. So primarily, what did we do? So you just find out which are the top 20 queries that actually the insurance kept asking you, right? Or the mistakes that we did. For example, the CT scan went, but the film was not, right, etc. And so this is something that we need to understand and see, can you solve this problem by adding that element into the process, by doing an analysis of your previous 10 queries or previous 100 queries that has come from the insurance company, because they are bound to ask and we are bound to give. So there's no escape, right? So I think communicating with the insurance community, whoever is sitting there for discharge or a SPOC that's identified for particular hospitals, is very important to tell them that, well, this is my data. I have analyzed this way, right? So these are the queries you have asked, and now I'm filling up. So why are you coming back with this again? So either it's a system issue at their end or a system issue at our end, right? So I think there is a protocol that needs to change in terms of how we look at and how the insurance looks at the same, right? So for example, I still remember a case where the patient was admitted for hypoglycemia, brought into the emergency with hypoglycemia, and patient was not on any OHA, right? So patient stayed for maybe 1.5 days, 2 days, and then stabilized and sent back. Not known diabetic, nothing, right? But one random episode of hypoglycemia. So the query that comes at least 11 times is, can you tell us the OHA? Can you tell us the insulin? So it's clearly written, right? That there is no OHA, there is no history of diabetes. So this is the problem, because you look at it from the insurance company perspective. They have to save their sanctions. It is their target, right? So I think it's important to bring harmony at that end, right? Rather than trying to look at it only from our process perspective, because there is an important harmony that needs to come from their end if they have to talk about it. Because given the insurance penetration in India is now exceeding 18%, you would only expect more and more patients to come with insurance and less with cash, right? So that's the third point I would like to make. The fourth point I would like to make is more to do with technology. So, something as simple as WhatsApp groups to something more complicated, where HMS is completely updated to show scene by scene, right? Where you can track the activity on a process-based, step-by-step process, like a time motion study, to find out where we are actually getting stuck physically. Because without man, this is not going to complete in any case. So, where are we getting stuck physically? Who is the team, or which is the team that's actually going to work on this? Is something that we need to right. And I like Dr. Devanand when he said, we need to fix accountability. But my question is who, right? If you chase the operations manager by not giving any solution to him, it's not going to work. He's only going to get more slimmer, leaner, and better. Right? It's not going to work. So there must be some technology that's available to him, something like a PDA, something like people can watch the status, something can track. So this is something that we did well. Particularly evolved during the COVID, because a lot of people thought, it's easier to do it that way. So I guess that's one solution that I would like to propose. So use technology to make sure that there is a hands-on data and there's a real-time data. So if hands-on and real-time data is available, right, I still feel that the operations team or the customer care, whatever is called in the respective hospitals that we are speaking to, we'll be able to find something that's more lively, for people to therefore even be questioned, right? So it's important because we normally question in the morning meeting dashboard and say what happened yesterday, right? And then we slice the data and say, okay, 60% is cash patient, 40% is insurance patient, out of the insurance patients went in 4.5 hours. So these are all general ward, etc., etc., etc. Corporate patients are 12%. So 12 corporate need not stay for more than 1 hour. So we have our standards, but I'm still wondering where the standards came from, because we've done it with our own self without even talking to somebody who is approving the payments, right? And number 5, my last perspective, finance and audits need help. If finance and audits need help, billing will take time, and we need to acknowledge it. Question is, are we prepared the previous day? Answer is, that's very, very true. You need to be prepared previous day. You need to see what's happening. And that's where the plan of care needs to be written. And that's where the discharge planning is very, very important, like many of my speakers have alluded to. But like Mithun said, it's not so easy, because discharge planning is something that doctors don't do, right? And they have the right to do so, right? I'm coming from a purely administrative perspective, right? Because most solutions have already been discussed with all my colleagues here. So I think it's important to look at some of these 5 aspects. And the last one, asking surgeons to sign and asking them to be the OT and also attend an ER case is very, very unfair. Back to you, Dr. Naveen.
Thank you. Thank you for that. This is from the Six Sigma Green Belt, Black Belt, and Indian Statistical Institute alumnus as well. So thank you so much. Many of the perspectives which are relevant. Just a point, when it comes to 65 to 70% occupancy, we're also taking into account the weekends where it becomes lean. So when you average out, so it's probably fuller on some of the days, but then it is relevant. We have to look at it very objectively. We are moving on to, there was one friend of ours who came and joined the conversation, and he said, "Hey, I'm a PhD." None of us knew he was a PhD. We said, "Really? You are a PhD?" He said, "Yes, I passed high school with difficulty." So we all had a good laugh, really appreciated his sense of humor. But we have a real PhD today with us, Dr. Santosh Kumar, MHA and PhD, and many other degrees which I cannot pronounce. So a lot of awards and the fantastic background internationally. So over to you, Dr. Santosh Kumar, to listen to your perspective.
Thank you, Dr. Naveen, and I must first congratulate and thank the CAHO team and Dr. Renjith for allowing me to present my thoughts about this delay in discharges. I think we all know that delay in discharge, as everybody said, is an old age problem, and it's a global problem. For, last 25 years, I've been hearing about, from the time I started my career, we started hearing about the discharge process. And every now and then there are different studies and all that. So what I'm going to do is that I'll talk about my case study from my hospital. Of course, as Dr. Ananth said that, why we should talk about discharge at all. We know in global, I hear from my colleagues from Europe that if the patient is waiting in the emergency, there is no bed, so they are being treated in the ambulances. I hear from the US that the long home health care patient and all that, they need hospitalization, but there is no bed, so they have to again be kept on waiting, and so the outcome of the care gets affected. In our case, like I'm talking about this case when we started measuring this thing, and 2 years ago it was like 80-85% occupancy. We had 2.5 days is my average length of stay. So delay in discharge, it becomes even a bigger problem, because there is the patient who has to be like admitted. There is no bed, so they have to keep waiting, and those who are to be discharged, of course their annexes, it takes time, so their satisfaction level goes down, and of course everything is a loss of revenue, because we are not able to get patient admitted who needs, especially in case of surgical cases and all that. So obviously it is a efficiency, effectiveness and quality issues, and ultimately it is hospitals' losses. especially if your occupancy is high and average length of stay is low, so there is no space and patients are waiting for surgical procedures or admission. So this case, when we started measuring in 2019, our average length of the discharge time was about 4 hours. TPA, it was more than 5.3.5 hours. Corporate cases 4 hours. So and of course, with the expectations from patient is, of course, the patient should be discharged instantly. If it is like everything is online, then we can of course give that kind of thing, like the patient, if services are billed, and then at the time of discharge the bill is prepared and patient is discharged. But since that is not the case, it is important to understand the different delays and then different stages at which the delays happen. So as we all know, discharge is a multi-step process which involves a lot of teams, and of course every stage, right from consultant, marking the patient, nursing staff, ward, transcriptionist, drug return, billing, and all that. Every stage is a potential for inducing the delay. And it's not only the delay at the processes, the delay in actual physical transfer of the files and all the resources that causes the delay. And this step, we all know that again, the causes for delay, some in case of TPA is external, for which we can't do much more about that. But of course, the patient doesn't know that whether it is internal problem or external problem, they get kind of furiated. So what we did based on the kind of different analysis, that of course we put different people responsible for discharge as a coordinator, and the like other hospitals, like first the consultant used to come, there was a delay in the consultant's round, or sometimes the consultant will mark the patient for discharge, but then they will not communicate to the patient, so patient will still wait for next day that I will get it discharged only after consultant sees me. So even though consultant has written that the patient needs to be discharged next day, it doesn't happen. So we started coordinating that advanced planning, discharge planning happened. We had a kind of WhatsApp group in which every day, like nursing staff will say that in my ward, there is a one planned discharge. Every day evening, the WhatsApp message will come, and then nursing staff are required to do complete the files. Night RMOs will do the complete file and the drug return, which is a major issue, especially in case of the cash, the corporate cases where the patient has to be given the medicine from the hospital. The patient will wait till they get the medicine and all that. So color coding in our dashboard. So for mark for discharge, billing is done at different stages of the discharge process is given different color codes, and then somebody monitors that, so that if there is any delay, why it is that, and then we can speed up the whole process. In case of TP, we have also seen that different TPAs have different software. So one has to open different modules and then keep on uploading the software, and then they have to see open to see what is the update, what is the status of the TP's responses. So now we also got the single window software, where in one window you can just pick up the software, the TPA, and then you can upload the things. And it also kind of helps the monitoring of the cases for the patient, of course, displaying the TV display. This is again, like it's like when you go to, if you know the process, you anticipate what is going to happen to your status, and that doesn't improve the delay in discharge, but it actually involves the patient at different stages, and so the anxiety level reduces. So kind of helping patients to understand. We have also had, of course, like any other hospital, we started doing this counseling of the patient for billing and all that. So that happens on a daily basis, so that the patient is not got surprised by seeing the sudden bill increase in the bill. And proper counseling, that some bill is already it's not possible to have a 100% updation of the bill, and some percentage of bill variation might occur because of delayed in the posting the services being given to hospital. We also started tracking at every stage. So you could see here that nursing station, doctor's room, transcription. So at what time file moves at what level and how much time it took. So that happens on every day and every file we do. And at the end of the day, today itself, I found that there is a huge discrepancy as per our expectation. So now the average length of stay, average discharge time has reduced from 4 hours to 3.26 hours in general patient. And of course, TPA still it is higher, 4.36. But and this variation, I'm talking about the common causes, excluding the special causes which we can't anyway do much about. So there are some other intervention we have in planning is like use of speaking softwares, because they say that software, if the doctors instead of writing something, if they dictate something, it helps get type for 3 times faster. E-help to get the digital signature of the patient. This is in case of corporate cases. What happens is that it is mandatory that the customer satisfaction level and all their signature has to be taken. So my staff would get the printout of the file, the case, and then they will get the signature, scan it, and this happens every time. So that kind of increase the time. So we are getting e-signature and digital signatures on the PDF. It's just like you get Amazon thing, and they will get this your signature on the POS machine itself. So that kind of thing we're trying to integrate, so that on an electronic file itself we get the signature of the patient. So it saves a lot of time for scanning and rescanning. Sharing same digital signature again for the corporate cases. One organization they will give one digital signature, and there are multiple files to be processed together at the same time. So that again creates delays the process for the corporate sector. So we try share the different computers, and with the same digital signature, one can use to reduce the delay in discharge time, especially for the corporate cases. There are, of course, there are different softwares which will actually kind of capture every information related to discharge automatically using the artificial intelligence software. So that actually will reduce the time of transcription, writing doctor by note by doctor, transcription again, verification by doctor. This is what is in, and of course, billing summary digitization is. So this is the software I'm talking about, where we are implementing right now. So it captures the chief complaint for the patient, the vital signs from the patient, the surgical details automatically it captures from the surgical notes of the hospital, medicine given from the indent, and prescription from the hospital. So if that start happening, of course, the discharge preparation, sheet preparation will reduce, and other thing concurrently happening. The discharge, we expect that the discharge will not be instant, but of course will be much reduced. So since rest all of the sharing, the kind of findings is same, I share the same thing. So I would like to conclude that of course, discharge, it is not possible to reduce the discharge to a 0 level, discharge time to 0 level, but yes, it can be reduced to a great level. And of course, proper discharge that can happen with proper discharge planning, counseling of the patient, electronic chart of medical records, robust insurance claim management system. As I said that from same software, one can interact with different TPs and all that. And of course, engaging patient during the whole process, which will not help reducing the discharge, but at least they are part of every procedure. So either through sending message or through the video description and all that will help a lot. So with this, I end my presentation. Thank you.
Yeah, thank you so much. Lots to digest there. So we will also be circulating some of these things. We will move on to the finalists, the last two, and Mr. Mahendra Pala, Chief Operating Officer, Mallareddy Narayana Hospital, from the happening city, Hyderabad. So lots of experience as facility head, P&L management, sales, international sales, marketing, digital PR, branding, with a lot of awards and academic credentials. Over to you, to Mr. Mahendra Pala.
Yeah, good evening, sir. Good evening. Good evening, everyone. Request, and first of all, I would like to thank the CAHO team for the participation and also to share my experience in this platform. So yes, Prakash, can I just flash the screen, flash the presentation? So as Dr. Naveen was mentioning, the dynamics of each state is different. But when I say this across working across the country, the dynamics of each zone in Hyderabad is different. So this very specifically I'm mentioning. The reason is this is a North Hyderabad zone where my facility is there, which is the largest facility of North Hyderabad. And what I've seen is the discharge delays. I want to look at it in a different way. You said their loss or yours. So I was trying to see how it can be a gain. So I was just seeing how it can be a more engagement with the attenders or patient. It can be gained to them by leaving the hospital. Then be a gain to my team who is involved in that. So 2-3 things we have done as a broader way. One is about enhancing the communication with all the stakeholders. And most important thing is have to improve my case mix so that I can accommodate more number of cash patients. And my agenda was very clear, only to focus on cash discharges. I know the problems, I know the limitations of PSU corporates and insurance companies. So while admissions of insurance and PSU corporates, we make them very clear as Beena informed. We follow the same technique here, but the focus is only on the cash patient, only on the cash patients. So I will talk about the improvement journey, what we had, what we started in April, May, June, the first quarter, and now currently. And also we have done some policing initiatives, which I named it as COP, and we have that monitoring methodology also. Can we just move to second slide? Yeah. So as I said, we are focusing only on the case mix, that is improving our case mix, and discharges is only for cash patients. So initially the cash patients were only with cash and insurance. We were at 53 and PSU 9 and 38, and the average discharges was more than 5 to 6 hours. So before 12 noon, forget it. It's almost like a nil. And 12 to 2 was 4 discharges, but there was only a provisional discharge summary was given. There's no actual discharge summary was given. And 2 to 7, a lot of chaos and a lot of problems. So max to max, we were able to discharge 18 to 20 only cash patients. And as I said, accommodating patients, especially the cash patients in the new annex building, which we have thought of only for cash and insurance. So accommodating, though we have the facility, we were not able to accommodate the cash patients. And there was a high transcription errors, though the consultants were writing, but it was not transferred it properly by the DM. And we have seen there is a habit of extending the provisional discharges was quite high, and the stakeholders were just working in silos. So what we have done, we have taken just a baby steps. As I said, we formed a team and enhanced the communication among the team. And currently where we are now, where we have almost improved 15% of cash and insurance patients, we have jumped from first quarter to third quarter. And the average discharges turnaround time is coming up to 120 to 150 minutes. And before 12 noon, we were able to now do at least 6 discharges, and 12 to 4, it's almost doubled. And thereafter 2 to 5, there's almost 14. So as cash patients were improving, we were able to give them a service, especially by early discharges. And we have seen there is a lot of patient experience has improved. Transcription errors have reduced. It's not disappeared, but it was reduced. And we were able to do the hard copy of the discharge summary, and also we were able to also give the soft copy of the same. So how did we enable this? So can just go to the next slide, please. So how did we enable this? So we have just taken 3 initiatives, which was, as I said, it is a policing kind of a thing. But when I say policing kind of thing, it is a incentive based. It's completely incentive based. Every quarter, the entire team would get cash awards kind of a thing by doing all this. So clinical perspective, we have identified the very senior DMO, and we have a pool of DMOs because our hospital is in the 80 acres of land where there's a Healthcity supported by 2 medical colleges. So I have no dearth in PG students or DMOs kind of a thing. And the team exclusive what we formed has a clinical pharmacist, nurse manager, and 1 DMO. And there will be 1 exclusive DMO working in the night also. So 24/7, we want to just focus on ensuring that cash patients are discharged by 120 minutes or 150 minutes kind of thing. And especially we ensure, all my medical services team ensure that every day morning there should be a clinical huddle for this cash all these planned discharges, and these patients are pushed to one particular ward. As operational side, one of my fellow panelists told about the discharge lawn, we have created a discharge lawn and quite a spacious area we have. We have created a discharge lawn, but just beside the wellness department. And in that discharge lawn, we have placed the concierge services. We are trying to facilitate a lot of things to the patient and patient attendants. And also, we extend a lot of value-added services like that particular discharge launch. There will be a continuous tea, coffee servings and small services where we don't charge at all. And coming to the patient attendance engagement, whenever there is the moment the patient moves to discharge launch, we ensure that the attender is giving a major problem. So we engage that attender by just pushing them to wellness department and keeping them engaged with the basic checkup. And also we'll ensure that we give them 5 to 10 coupons per discharge, pinned to the discharge summary. And also we ensure that they give the privilege cards of Moderator hospitals. So how the impact was? Yes. So increase in discharge summaries before 2 p.m. has increased, and the relationship between the doctors and the DMOs and the administrators have increased because the senior DMOs with the consultants were regularly communicating with them. And we have seen there's a positive feedbacks coming up from the in regards to patient experience. And the most important, when I said good for the patients and the attenders, so walk-ins for my wellness has increased, number 1. Number 2, we found that we are really developing a genuine database of patients and their surroundings. Whenever they come for a privilege card, not only the patient attender details, we take the entire information of the patient attenders, relatives. We just give them the privilege cards and we try to collect a lot of data. And this would give us a lot in a helpful in a lot of cross-selling kind of thing. Next. So this is one of the tracker we every day it is being submitted by the clinical pharmacist. So I've seen the total discharges. We ensure that what is the percentage of discharges between before 12 to 2 and after 2. And we also plan the discharges summary, which is ready without billing, with discharge summary or provisional. So all these things we closely monitor. But the most important thing, as I mentioned, right now we are focusing only on cash discharges, and I'm able to accommodate more cash patients here and improve my case mix. And you can see the second tracker, which is about the cash patients, and we all do all these things. So these were the basis on the dynamics of this part of the city of North Zone of Hyderabad, and the Bellary, which is having a backup of a lot of medical colleges. So we are doing all these things here. So thank you very much for this opportunity once again. And one thing, Dr. Naveen, I have taken your point where you said that discharge summary can be printed in the ward. Now I'll take that and see that the discharge summary is taken, print and discharge launch itself, which I was not doing. So I will do that. Definitely I will do that. So thank you very much for patient list. These are my some of the issues. Thank you.
Excellent. Thank you. And the point that discharge lounge should not look like a punishment. It's a reward that you keep them very engaged. Thank you for that thought and many other things. And we will move on. I think lots of matter that you have brought up. We have the lady who's waiting, Dr. Sushila Kawade. After Hyderabad, it has to be Pune, of course, and the medical superintendent of Rao Nursing Home and chairperson of CAHO in Maharashtra, program director, faculty for CAHO, NC closure program, faculty for infection control, patient safety, and specialist lead auditor for ISO. So thank you so much for being here. Over to you.
Thank you, sir. First of all, good evening to one and all. So thank you very much, Dr. Naveen sir, Renjith sir, Father Johnson and CAHO family, who has given this opportunity to express my thought. Being what I would say, quality and operation person, and having the experience of academic hospital, university academic hospital, as well as corporate hospital, I have my few observations which I am going to present. Already my co-panelists has talked very well, and they have given us excellent innovative ideas on the discharge delays or the losses. So topic of today's discussion is discharge losses, theirs or ours. So here I would like to point out that obviously it is a loss of the patient along with the hospital loss. Why? Because if we are delaying the discharge process, of course, it will give burden on the hospital management because it increases the running cost of the bed. Being operation head, I definitely say that it will increase the running cost of the bed and it will give exposure to the patients for the maximum, what do I want to say, HI or like infections and all. Once the discharge process get delayed, they will get most exposed for the various infections. So, and definitely this delay in discharge gives bad stamping over the good journey to the patient while leaving the hospital. And that's why we should not do this. So if we would like to take out a white paper in the India on the discharge delay, definitely we should consider structure of the hospital. For example, it will be different for corporate and it will be different for academic institution because of their complexity. So in my year of experience, I came to know that after doing a lot of analysis and continuous monitoring of the discharge process, it's very difficult to achieve the benchmark. Once we achieve the benchmark, again, it goes down after a certain time period. Why it is so? Because it is a multidisciplinary team approach and all stakeholders of the hospital, not only internal, but external stakeholders like government schemes, EPAs, and even patient relatives and families are also involved along with the hospital, various department staff. So after doing analysis of our hospital discharge process, initially our problem was our cash discharge time was almost 4 hours and TPA was almost 4 to 8 hours, which was very huge. So after doing the process analysis, data-driven analysis and introducing the discharge tracker in the hospital, we came to know that as already explained by various team members, discharge delay was, after doing the Pareto analysis, we came to know that doctor and the billing department was the 20% responsible person who gave the 80% delay in the process. So we come up with the intervention that in the various big hospital like medical college as well as in the multi-speciality corporate hospital, we came to know that planned discharge, though it is on the paper, actually no one is planning discharge 24 hours prior. So we should have a elective discharge process very thoroughly. They should plan the discharge. Also night doctor, they should start preparing the discharge summaries in advance. I know discharge summary is the actual image of the hospital or it is impression of the hospital patient care which we are giving to the patient to publish outside the world. So outside in the community. So it should be a skillful, rather this document of discharge summary should be prepared in skilled manner. It should not be done by any Tom, Dick, Harry who has no knowledge how to make the discharge summary. It is a skill, I would say. So we have trained our doctors, ward doctors and consultant. What are the salient features you should beautifully mention in the discharge summary because it is an impression of hospital care. So after doing the analysis and all, we came to know that HMI should be supportive to do the real time, to monitor the real time data for the discharge summary. Because if we are monitoring all the, though we introduce discharge tracker in hard copy, as rightly said by Santosh Kumar sir, it's very difficult to map all the processes because human intervention is always very, what I would say, very risky because there are chances of hiding the data. That's why this digital tracker has to be there to map the discharge process. So of course, hospital should have a HMIs in place, a proper HMIs in place who can capture all the data with real time. Then we have started in our hospital that early consultant rounds. So in our hospital, we have started a consultant round at 7 a.m. in the morning. So that once they go to the ward, definitely they will give discharge order. And of course, we have displayed everywhere in the patient care areas that turnaround time for cash discharge will be 4 to 5 hours and for TPA it will be 6 to 8 hours. So that type of benchmark already we have been displayed in various patient care wards to give what we say early briefing to the patients so that they will not sit on the head of the hospital. Then longer duration patients, rather day to day in our hospital, what we have introduced that billing ward coordinator. They are like floor manager. Daily they are sitting in the ward, daily they are updating the bill and informing to the relative and ensuring the recovery at the end of the day. That's why definitely this discharge time from billing has cut down. Then daily file checking by all nursing in charges, because nurses definitely will take more time to check the file before giving to the pharmacy for bill clearance and for the medicine return. That's why we have introduced that ward in charge will check daily all the IPD files, and she will ensure whether ward activity is properly being filled or not, which is used as a billing charter. So this we are continuously doing in our hospital. Also, patient safety champions are empowered and promoted to take a leadership role in ensuring their wards discharges has been done within defined timeline. Then porters are exclusively kept in the hospital. Those who are also giving this file to the different departments. In few hospitals, they are also having pneumatic chute system to give this file to the various departments to cut the cost of the transportation. And also, relatives should get daily updated so that they will pay the bill on time. And it is also recommended that when this payment process is in the process from relative side, we are ensuring that discharge kit is ready with the hospital nursing department. Means discharge kit should have one copy of all reports, one copy of discharge summary with the receipt and all. So that type of discharge checklist is separately made, and which is they are utilizing in their respective wards to ensure that patients should get a smooth sailing physical discharge. And already my co-panelist has said that they are having discharge launch in our hospital because of in medical college. Even in the corporate hospital, in some hospital, because of the constraints of space, it is not possible to have a discharge launch. But we are giving, we are not charging to the patient once the discharge has given. And sometimes relatives are taking time to come out from their office and to pay the bill and all. So we are taking out this patient from the data, as well as complimentary. We are providing food and any other support services to the patient at free of cost, so that they should not feel that once the discharge has given, we are not getting any services. So after implementing all this intervention, we came to know that still this percentage has really not come down very well. It has just reduced by 30 to 40 minutes, but still it is very Herculean task to break the bottleneck. So these are what challenges I have faced. So I would say you all must be agree with me that it is a multidisciplinary process. It should have a team approach. It should have a leadership quality. It should have a good supportive HMIs in the hospital, as said by sir, so that all the data entered by lab, even doctor, radiologist and all should get collated in the discharge summary template. And checking and verification has to be there, because language of discharge summary is very, very important for the public once patient get discharged or patient get out from the hospital. So if we would like to design the policy or a white paper, we should consider government scheme patient. We should consider protocol for cash patient as well as different protocol for TPA patient. So this is my concern from my side. Thank you very
so
much.
I think it was quite loaded, but we will make it. It'll be included in the final white paper that Renjith will coordinate. So thank you so much. For I think multiple things have come up from so many different sources and a lot of practical things. So, but it is a problem. It is a problem that we must continue to address, and aggressively so, because it is worth it. Because from the patient perspective, it's a big issue. It's a big issue. We may get bored of this issue, but we should never let go of that. Keep working.
It was nice. Thank you so much for your participation and time, and we will create interesting topics on the operations and risk management in going future. We will make and invite more CXOs so that we have a larger knowledge enrichment on various topics. This was an interesting topic. Discharge process is a war. Every day is a new scene for different hospitals, different dynamics, different mix of beds requirement. I implemented a bot-enabled process. I removed the MIS preparation by all my managers. The doctor given a tab to attach digital signature and approve the discharge summary. The priority mix of which bed is required and where is the demand and where we need to focus. was also laid down, and there it's a rich. I think we need to have another session on this with the second line after our white paper. So thank you so much and have a great evening.